First question. How can we make the genetics of pain more easy to explain to our patients? Dave, how do you explain it?
Take time. That's a good question, actually. I mean, I think genetics, so certainly those Mendelian pain disorders, I devote a lot of time explaining the problem to patients. I think some of the hardest issues are actually where we're not sure about pathogenicity. So, for instance, there are quite a lot of variants in the ion channel I was telling you about, NAV 1.7, and not all of those variants, as you may imagine, are pathogenic. And then you need to start doing both tracing within a pedigree for that variant and also some functional studies, which can take a long time. So I think the difficulty actually of explaining this to patients is some of the difficulty in describing the uncertainty of being sure as to whether that gene change is actually relevant to their pain state. And I think you just have to be completely explicit about that, and you need to have some expertise in the particular field. I think increasingly I liaise very, very closely with the Department of Genetics at Oxford, and we certainly share some patients so that you have both the genetic counselling expertise but also someone that has expertise in that particular condition, and that's the way I would go about it.
We have another question.
Francis Williams, King's College London. Question for Francisca. That was a fantastic talk. I wondered if you could just say a little bit more about how you reconcile your first comment about methylation being stable with the subsequent slides that showed that it appears to have an influence and it clearly changes. For example, over the course of the lifetime, you didn't show this, but we know that it changes in response to cigarette smoking. How do you think those changes are managed, and in what way are you saying that methylation is stable?
I suppose I highlighted the stability point because I felt, and I mean you must have felt that as well, that up until about 2010, it was the dogma in the field that, for instance, certainly DNA cannot be demethylated. There was no mechanism, nothing was identified. And so we went from that within 4 years to, oh, DNA methylation changes within 4 hours everywhere in the hippocampus. You know, it's a bit much. So I guess my view, not that I'm a complete expert, is that in most places, in the majority of the sequence, you know, we have so much sequence that needs to be silenced. The majority of the sequence, DNA methylation is stable. But in important regulatory regions, like enhancer regions, like CPG island shows, you do get the variation. So I think we obviously should study it, but I think it's important for people to realize that a lot of it is fixed, and we really need to be able to hone in on the places where it does vary.
So are you saying that it's fixed through the gene body, but it's the enhancers that are susceptible to change and alteration through environmental stimulus? And if so, how is that maintained, do you think?
Well, I guess I'm not sure that that is known, right? I guess that's just what you garner from, if you look at all the ENCODE big studies, that whatever, that Ziller paper that I quoted, that is pretty much what they observe. But I think we're quite far away yet from being able to explain why that is the case and also how it's regulated. I mean, even during development, how is it possible? Where is it remembered where the DNA methylation has to go back once it's been demethylated, right? It's demethylated and it has to be remethylated. Where is that signal? I think there's a lot of mystery still.
Thank you very much.
Yes, of course. I think.
How do you get it on? I have a question to Dave. I mean, why do you study all these experimental pain models when you have an experimental pain model every day around the world as a surgical operation?
Of course, we should be studying both. I mean, we studied it because in some ways it's more tractable. If you're looking at a quantitative trait, that provides some help. If we're looking in a very uniform population of young, healthy students at a university, these are all ways of reducing confounding factors. obviously, actually, the real proof in that, well, I think those experimental pain studies, our hope is they'll give us insight into biology. Obviously, the ultimate test is we will have to do it on patients. And actually, we are starting to do that. But I can tell you the phenotyping, for all the reasons you suggested, is even more complicated. I mean, I may be wrong, but I suspect that the surgeon performing the operation has an impact on the outcome. Would that be a fair comment? So those are the kind of factors we would be dealing with if we were trying to apply those methodologies to cohorts of patients. Now, we will be doing that, but I think it's a particularly challenging environment, particularly for genes that are having a very small influence, which I think is going to be the case in post-surgical pain.
But I think one very interesting aspect is that if you do QST assessment in different types of surgery, you can find a large group of patients who have signs of nerve injury, but they have no chronic pain. So it's a fantastic opportunity to identify the genetic mechanisms on why nerve injury in some patients lead to persistent pain versus not.
It's true.
I completely agree. We just need to persuade the MRC to give us a few million quid to do it. But that's not always such an easy story to sell, because. I mean, I completely agree that it's an interesting question, and of course, it's the same issue with diabetic polyneuropathy. Why do only 30 to 50% of patients with diabetic polyneuropathy get pain? The other 57% don't. As I said, I don't think all the answer is going to be genetics. Much of the answer may well be psychology, previous experience, etc., etc. But I think it'll be one factor.
We have a couple more questions on the app. We have opioids are known to methylate DNA. Does this methylation affect pain processing as well? There are a couple of studies of the methylation of the opioid receptor gene in pain. At the moment, though, they were done in I think, not really the relevant tissues. So I would say we don't know yet. But I think it is something that would be interesting to look at. And then, how may epigenetics in chronic pain be reversed? I mean, I'm not even sure that we have really conclusively shown yet that it does something. I just think that intuitively you feel like it has to do something. If we then really become convinced that it does something, there are drugs, and actually the pharma industry was very interested for a while in HDAC inhibitors that interfere with histone acetylation because they use them in cancer and so forth. So the hope is that there might be, by the time we figure out what's really going on, hopefully there will be some selective compounds that maybe would allow us to specifically interfere with the enzymes that add and remove these histone modifications, for instance.
I've got a question for you. And do you think you could give those drugs, so going back to Henrik's model, do you think you could give those drugs almost preemptively? Say someone's having surgery, you start the drug 2 days before surgery, continue it for a week.
I guess. We're going to get skin to say it. I don't really believe that personalized medicine is likely to happen. Sorry, Ralph. Just because, I mean, mathematically, I think it'll be very difficult to really predict in one single patient what will happen.
Sure.
But yeah, I guess one could, yeah. No, another question. Is there another question? Oh, do you think the epigenetic changes caused by early life experiences could be reversed by effective long-term surgery? Yes. Personally, I mean, that's just, now we're just talking about what Franziska believes. But in my view, the brain functions just like a muscle functions. You know, if you exercise it in the right way, if you could find a way of tapping into the circuits that are dysfunctional, I would imagine that we could maybe reverse some of these changes. Yeah, that would be a hope, I guess. All right. Shall we wrap it up if there's no more questions? Thank you so much to our audience. You've been great.